Log on, tune in, find out. Another good idea from Cambridge.
Well, thank you, Sandra, very much for the introduction and especially for the invitation to this meeting. It's a great pleasure to be here, and I've enjoyed this afternoon particularly. I'm an ethicist, not a biostatistician, so I should make that clear. So no mathy questions, please. And I've been very interested in really the interaction between trial design and ethics for a long time. But it was really only since arriving at Western in 2005 that I became acquainted with the cluster randomized trial. Since 2007, I think, Alan Donner and others, Jeremy Grimshaw, Martin Eccles, Monica Talliard, have had a project on the ethics of cluster randomized trials. And it's been enormously interesting learning about cluster trials. And I have to say, the ethical issues that are driven, I think, by aspects of the design of cluster trials, I personally find enormously challenging. So I'm going to talk a bit about some of the preliminary conclusions that we've come to out of this project, and I'd very much like to hear what you think about some of our preliminary conclusions. And I'll say a bit more about the project itself in a few moments. Well, as I said, I think cluster trials pose ethical difficulties because of features of their design, and there are a number of features that I think create challenges. First off, cluster trials involve groups rather than individuals. We've got a very clear sense when we're talking about individuals about their liberty and welfare interests, and we sort of think that it's very important to protect those things. But when we talk about groups, the moral status of groups is a good deal less clear. And I think that creates one of the central challenges with cluster randomized trials. A second feature of these trials is the fact that the units of randomization, experimentation, and observation differ within any given trial, and that creates complications. For instance, it can be difficult to figure out just who the research subject is if these groups, if these units vary within a particular trial. We've heard mentioned a few times this afternoon the fact that clusters may be randomized before individual cluster members may be approached for informed consent, and that may pose ethical challenges. And finally, the picture is complicated by the fact that study interventions may be directed at individuals, at clusters, or even within the same trial at both individuals and clusters. So all of these features, design features, I would submit, create ethical challenges. I want to start off just giving three examples of cluster trials, probably ones you're familiar with, and as we go through the three ethical questions that I want to talk about this afternoon, I'm going to appeal back to these examples, right? So the first is a study from Cambodia in which about 36 communities were randomized to receive insecticide-treated bed nets or no intervention to prevent malaria transmission. In the intervention communities, bed nets were distributed to all residents in the community, and a variety of data were collected, but most significantly from, I believe, a random sample of individuals in the community. Blood tests were drawn to look at the prevalence of malaria in the intervention and control communities. No identifying information, however, was collected. The study found non-significant trends towards decreased malaria. So that's the first example, bed nets to prevent malaria. You've all heard of this study, the COMMIT study, which was a trial of, I think, 22 communities conducted in the United States and Canada, I might add. And this was a study using multimodal community-level interventions to reduce cigarette consumption. The data collection involved interviews with a random sample of smokers in each community, and they found an improved quit rate for mild to moderate smokers, but no effect on truly committed heavy smokers. The third example is a study looking at improving the prescribing of antiplatelet and lipid-lowering drugs in primary care practices to patients with cardiovascular disease and diabetes. And there were two interventions. In one arm, general practitioners received a personalized summary by mail of their prescribing practices of these two categories of drugs, plus an educational visit. And in the other arm, they just received the personalized summary of their own prescribing practices. Data collection involved on their prescribing practices were derived from a national pharmacy insurance database, and these data were aggregated by physician and contained no patient-level identifiable intervention. And the result was that both interventions led to similar improvements, which I guess is just an optimist's way of saying it was a negative study. So those are the three examples that I'm going to come back to, but I think one immediately gets a sense of the heterogeneity in terms of design and subject matter and so on in terms of cluster trials. Well, I've said that because of design features, cluster trials pose a number of challenges to our current understanding of research ethics. And I think currently there's just a lack of sufficiently detailed, sufficiently comprehensive, and sufficiently authoritative guidance. And I think that creates difficulties for researchers. It certainly creates difficulties for research ethics committees and regulators who have no single international standard to guide their review of cluster trials. And this all, I think, combines to create uncertainty and at times markedly different interpretations as to just what are ethically permissible practices in cluster trials. So it's really this feature that led to the creation of our research group. It's a group funded by the Canadian Institutes of Health Research starting in 2007. We've been running for 4 years now, and this year actually have quite a lot of papers coming out of this group. As I mentioned, the PI is Monica Talliard, and it also involves Jeremy Grimshaw and Martin Eccles and Alan Donner, of course. The objectives of the study are really threefold. First is to document practice, and we're really doing this through a mixed methods approach. We're trying to get a sense of what sort of ethical issues do people identify in cluster trials, what do they report in journal articles and so on, and what do research ethics committees report in terms of the challenges, and we also want to talk to cluster trial participants as well. So we've done a mixture of sort of interviews. We've collected actually a random sample of 300 published cluster randomized trials. We're surveying trialists, ethics committees, and running some focus groups on trial participants. So lots of activity on the empirical side of things. We're also, in part, informed by issues that are coming out of this empirical data. We're trying to systematically analyze the ethical issues that we're seeing in cluster randomized trials. And so that's leading to a series of papers. We have a planned series of, I think, 7 papers coming out in trials. The first is an introduction, and then 6 sort of substantive papers, each engaging a particular question. The first 3 out of those 7 papers have been published now in trials. A fourth, hopefully, is coming out very, very soon. And then these ethics papers are really going to serve as background documents for the development of international consensus guidelines for cluster randomized trials. We're hosting an international consensus process meeting in Ottawa at the end of November, and then we'll be circulating draft guidelines for comment that come out of that. So it's really being quite a large project and an extremely interesting one to participate in. I'm going to focus in on the ethical analysis, and really we're addressing 6 questions. Who is the research subject in a cluster randomized trial? From whom, how, and when must informed consent be obtained? Does clinical equipoise, it's a key sort of ethical concept in standard randomized controlled trials, does that apply to cluster randomized controlled trials? How do we determine if the benefits outweigh the risks in CRTs? How ought vulnerable groups be protected? And who are gatekeepers, and what are their responsibilities? So the paper sort of motivating each of these questions was published in Trials earlier this year, and you can see the reference there. I'm just going to sort of preview some of the conclusions in 3 of these papers now. The first one, who's a research subject, the second one about consent, and then I think quite an interesting question around the use of gatekeepers in cluster trials. So I'm just going to focus on questions 1, 2, and 6. So let's start with the first question. Who is the human research subject in cluster trials in health research? It's actually an enormously important question for an ethicist and also for ethics committees and regulators, because the sorts of moral obligations that we talk about in research ethics and the kind of regulations that are found in national and international guidelines apply to human research subjects. So we have to know who the human research subject is in a particular study in order to know to whom these various obligations and regulations apply. So that's what I mean when I say that identifying research subjects is logically prior to the application of protections. And it matters that we get this right. One can imagine 2 kinds of error here. One is being really overly inclusive and calling too many people research subjects. Well, that's going to lead to the risk of unduly burdening research, and that would be problematic. Or the other kind of mistake we could make is we could be under-inclusive, and that would fail to provide protections to those who have a right to them. So the idea is that we really ought to try hard to sort of get this right. When we went to the literature and actually started looking, so there have to be some really good definitions out here, some good sets of criteria for the identification of research subjects. Actually, there weren't any. And that for me was very surprising. And I think it's because in individually randomized trials, where typically the unit of randomization, experimentation, and observation are all the same individual, it's really obvious who the research subject is. But it's this feature of how those different units can pull apart in cluster trials that complicate this question. So to me, that's very exciting, because this then is a question that speaks not just to cluster trials, but in fact a really foundational issue across all of research ethics. So anyway, so the ethics of cluster trials are really interesting. So what we did was, to make a long story short, actually come up with a novel definition of research subject that we're kind of hoping works across the board, and we'll see how it goes. But here's our go at it. That a human research subject is an individual whose interests may be compromised as a result of interventions in a research study. And we've associated this definition with a set of criteria. So a human research subject is an individual who's directly intervened upon by a researcher, or an individual who is deliberately intervened upon via manipulation of his or her environment, or an individual with whom a researcher interacts to collect data, or finally an individual about whom an investigator obtains identifiable private information. Now, of course, in any given study, a person may be a human research subject for more than one of these reasons, right? They can be intervened upon and private health information could be collected, right? But the idea is that any one of these would be sufficient for someone to be considered a human research subject. Now, I have to add as a caveat here that doesn't necessarily mean that you need to get the informed consent of these individuals. That's a separable question, and I'll get to that in a moment. But so this is the set of criteria that we came up with. And if we reflect this back now on the studies that I opened up with, what this would imply then, in terms of the BedNet study to prevent malaria, is that the research subjects, the human research subjects, would be residents of the intervention communities who received BedNets or who gave blood samples because they were all intervened upon by researchers, or it would be residents of control communities who gave blood samples because they were intervened upon as well. Okay. In the COMMIT trial, this definition would lead us to conclude that residents of the intervention communities were research subjects for two possible reasons. One, because of environmental manipulation, namely the public health messages and so on. We're calling those environmental interventions. Or because they were interacted with in the interviews that were carried out with a random sample of community members. In the control communities, it's only the latter interaction in terms of the random sample of people who were interviewed that would cause a subset of those in the control communities to be research subjects. Perhaps most surprisingly, though, is what this implies for the third example, right? The knowledge translation cluster randomized trial. First of all, because in fact the individuals intervened upon in that study were actually the physicians themselves. First and foremost, it's the physicians who are the human research subjects in that study. I think that's actually quite common in knowledge translation studies in health research, and a fact that I think hasn't been sort of broadly appreciated. It's often, I think, an open question in knowledge translation studies of this sort, whether or not the patients of physicians who are intervened upon are human research subjects, right? And in this particular case, since the patients were not intervened upon, and since private health information on the patients was not, in fact, collected, it causes us to come to the conclusion that in this case, the patients of these physicians, in fact, are not human research subjects. Now, in different studies, they might be, right? For instance, if private health information were collected, or perhaps if they were interviewed by researchers, or there could, in fact, be interventions on the patients themselves as well as the physicians. But in this particular study, we conclude that the patients are not research subjects. And that has implications in terms of not requiring their consent and so on. All right, let me move on to the second question of consent. I said it was separable in the sense that generally one needs to get consent from human research subjects, but there are exceptions, right? And we'll talk about that. Cluster randomized trials actually raise some really vexing difficulties when it comes to informed consent, and these difficulties have been recognized for a long time. They're particularly prominent when there are cluster-level interventions for two reasons. First off, it may make avoiding the intervention either very difficult or impossible. And if you can't avoid the intervention, that means that refusal of consent is effectively meaningless in those cases. And that's, if you really think that refusal of consent absolutely must be respected, then, that's a big problem. Another problem has to do with when the cluster size is very large. It may mean that requiring informed consent may make the study infeasible. And so that's a second challenge with cluster trials and consent. The third challenge is that clusters may be randomized before cluster members can be approached for informed consent. And that means that even if one is approaching individual cluster members for their informed consent, that one will still have randomized them without their consent, right? Alan mentioned this earlier. And the question is that a problem? If it is a problem, how do we deal with it, right? So those are sort of the three challenges that we had in mind when reflecting on this. What we did in this paper, and hopefully this paper will be coming out fairly soon, is actually go back to really foundational issues and say, right, so where we need to start is with the moral purpose of informed consent. And one way of thinking about consent, it's not the only way, but one way is to sort of think that ethically there's a moral imperative to treat people not as mere means to an end, but as ends in themselves, right? And what that implies is that I can legitimately involve people in my own project only when they adopt the ends of my project as ends of their own, right? So in the context of research then, if one thinks that this is the reason why, the reason why we get consent effectively is to say that, look, we can't use people merely instrumentally. In other words, we can't say, well, important conclusions will follow from involving people in this study. That's using people as a mere means to an end. What we need to do is get those people to adopt the ends of the study as ends of their own. In other words, to consider the purpose of the study, to reflect on their own values and beliefs, and to say that yes, in fact, I'd like to participate in that study because the ends of that study are important to me. And that's one way of thinking about what informed consent, more from a moral perspective, is all about. So then the function of informed consent on this view is to allow prospective research subjects to adopt the ends of the study as their own. And that, at least partially, justifies exposing them to risk primarily for the benefit of others. Okay? It also follows from this that if that's what consent is all about, then it turns out that consent is pretty important, right? Because not getting consent seems to mean using people as a mere means to an end, and by definition, by this approach, that's very morally problematic. So not obtaining informed consent requires careful justification, and in the absence of a justification for not obtaining consent, the study can't proceed. Okay. So I want to pick up on the conclusion that I came to earlier about how some people who are involved in cluster randomized trials are not human research subjects. This has important implications in terms of consent. If there are individuals, such as patients of physicians in knowledge translation studies, who are not themselves intervened upon or who don't have private health information collected, those individuals are not human research subjects, and their informed consent is simply not required. In other cases, however, and I'm thinking here of cases with cluster-level interventions, it may be very difficult to obtain consent where the clusters are large. Also, refusal may be meaningless in some cases. In those cases, I think the best option is applying something called a waiver of consent. And the idea is basically this, that it might be okay to not obtain consent in restrictive cases, namely when it's necessary to do so and when the risk involved is effectively insignificant. And if those two conditions apply, then it may be morally acceptable to waive the requirement for informed consent. And provisions for waivers of consent are found in quite a number of national and international research guidelines. Certainly, off the top of my head, Canada, the United States, Australia all have provisions for waivers of consent. And the Council for International Organizations of Medical Sciences, the CIOMS, International Ethics Guidelines, also allow for a waiver of consent. Okay. So how would well, before I get to the examples, let me say something about post-randomization consent. So I've said earlier that often in cluster trials, the clusters themselves are randomized before individual cluster members can be approached for their consent. The question is how big of is this a problem? How big of a problem is it? What should we do about it? I guess the conclusion we came to on this is that so long as informed consent is sought as soon as possible and before any study interventions or data collection procedures, that in fact consent to randomization just isn't required. Okay? So you don't need it. The reason we say that is because so long as you're approaching individuals as soon as possible, right, and before they're put at risk by any study intervention or data collection procedure, that in fact, through the consent process, they can adopt the ends of the study as ends of their own before they're exposed to any risk for research purposes. And if that's true, then it seems to me that the moral ends of informed consent are fully fulfilled by approaching people when it's impossible to do otherwise after the cluster has been randomized. This conclusion could be a little contentious, but I think this might be right. Something else that's very interesting to me is the question of, so if you're approaching cluster members after their cluster has been randomized, what should the content of that consent process be? And that's a really interesting question. And again, I've got sort of another two-in-one slide here. I've got another sort of contentious conclusion. I think that the content of that informed consent process could be tailored to the study arm to which that individual's cluster has been randomized, right? And then the reason I say that is this, that it seems to me responsible informed consent requires that an individual have a good understanding of the consequences of agreeing to participate in a study and the consequences of refusing participation in a study. In a standard randomized controlled trial, of course, when people are approached before randomization, the consequences of agreeing to the study include the consequence of being enrolled in any of the trial's arms. So it's really important to inform them of the details of the study interventions and data collection procedures in each of the trial arms. In this case, however, accepting enrollment in the trial means necessarily that they're going to participate in the arm to which their cluster has been randomized. The option of participating in other trial arms has been foreclosed for them. It's either participate in the arm to which your cluster has been randomized or don't participate in the study. And as a result, we think that it would be ethically permissible for the consent process to really just focus on the question of, if I agree to participate in this study, what's going to happen to me? And that seems to me to require a focus on the trial arm to which their cluster has been randomized. Okay. So, there may be questions about that one, I understand. So what does this imply? Well, I think for the BedNet study, probably one could argue that a waiver of consent is appropriate in this study, that it would be difficult to get the consent for the community-wide distribution of the bed nets, and that the risk posed by study participation is probably minimal. However, it also would imply, I think, that informed consent is required from the random subset of citizens or members of both intervention and control communities who give blood. It's feasible to get consent because there's an interaction with the individual in the blood draw process, right? So it fails to fulfill the infeasibility requirement. I don't think consent to randomization is required in this case. The COMMIT trial, I think, is a classic example of a study that would fulfill the requirement of a waiver of consent. Again, it would just simply be impossible to get the consent of every resident of large municipalities. And again, I don't think consent to randomization is required. Finally, in the third example of improving primary care prescribing, I think that informed consent is in fact required from the physicians in the study. But as I've said, the patients, at least in this case, are not human research subjects, and no consent is required. Finally, let me come to the question of the role and authority of gatekeepers in cluster trials. And I think gatekeepers are incredibly interesting because, as far as I know, they're unique to cluster trials. They arose, I think, out of concerns, particularly when there are cluster-level interventions, about not being able to get individual consent, right? Either not being able to get consent for study interventions when there are cluster-level interventions, or not being able to get consent to randomization, even if consent is obtained from individual cluster members after their cluster has been randomized. So I think both of those things really drove this idea that, right, we can't get consent in the usual way, so what we need to do is get permission of a gatekeeper. And that's reflected in the UK MRC cluster trial document from 2002. So a lot of the emphasis in terms of the ethics of cluster trial literature on gatekeepers has really been about the protection of individual interests, right? To say that gatekeepers have an important role to give permission to randomize, to provide consent for individuals. And there are some other roles here. But I really want to question these first two. The short of it is, I don't think gatekeepers are well positioned at all to plausibly be thought to have the authority to provide consent on behalf of individuals. That, if I were to be incapable of providing informed consent, consent would be sought from someone who, was either my partner or my parent or my child, someone who was very familiar with my own sort of values and life choices and so on, someone who really knew a lot about me and was in a morally significant relationship with me. Gatekeepers have nothing like that relationship with individual cluster members, and so it's really difficult to see how, in fact, they would responsibly be thought to have the authority to perform that role. I think when the gatekeeper is a physician or a teacher, there may be a rule to protect the interests of a cluster member by giving permission to approach a particular cluster member. I think a more plausible role for gatekeepers is actually in terms of protecting cluster level interests. And here one might think of cluster consent or cluster consultation as being important protections, and in some cases protocol approval. Cluster consent is a challenging issue, I think. Again, questions of authority loom large, and that it is only appropriately sought from what I'm going to say is a legitimate political authority empowered to make binding decisions on behalf of cluster members. So if one's actually proposing to seek consent from a cluster leader, that individual, to legitimately give that consent, would need to pass this moral test, right? And in the context of research involving communities, it's commonly thought that community leaders, in fact, community leadership may have this kind of authority. Even in cases in which there isn't someone who's empowered to give consent on behalf of the cluster, there may be a useful role for cluster consultation, which involves conversation, dialogue, partnership with the cluster, particularly if there are questions of cross-cultural concerns. And here I'm thinking research in developing countries in part, that this may be a very important mechanism. Underappreciated, I think, has been the fact that gatekeepers do have a role in protecting institutional interests. And so it's commonly the case that when cluster trials involve hospitals or schools or nursing homes, that the chief administrator of that institution will give permission. It's interesting, though, that what's motivating that permission in the literature to date has been conceptualized as permission on behalf of cluster members or the cluster as a whole. And I think that gets things slightly wrong, right? Because for one thing, it leads to concerns, and here I'm quoting from the MRC guidelines, sort of suggesting that there might be a conflict of interest in that role, and that even that the individual should not be thinking about institutional interests, but ought to be focusing on individual and cluster interests. And I think actually that's not quite right. That when cluster trials are situated in hospitals, nursing homes, schools, that there are legitimate institutional interests at stake. And this, in fact, requires gatekeepers to determine what impact a research partnership will have on an organization and whether that organization has the available resources to allow participation. And this decision is going to be based on really institutional factors like availability of staff and financial implications and so on. And so I think actually this is one of the clearest roles for gatekeepers, is to give permission on behalf of an institution where in fact what they're taking account of is exactly institutional interests. So in terms of the BedNet study, I think very likely there's a role for community consultation and consent. The commit study, same thing. And importantly, the improving primary care prescribing study, actually I think there's no role for a gatekeeper in that study. So we're posting these papers as they come out on a wiki, and we'd love to have your feedback, not only now, but also on our wiki. That's the website, crtethics.wikispaces.com, and really welcome your comments on the wiki and also now. Thank you.
Thank you very much, Charles. I thought that was absolutely fascinating. Any questions for Charles? Comments?
Yep.
This is a question about your definition of research subject, and in particular in example 3. Now, the patients were no research subjects, but if the intervention on the physicians had some indirect effect on the patients, would that change the situation?
Well, there's one paper out there in the literature on exactly this question, an article by Howard Mann. And the question came down to whether intervening on a physician with the idea that this would have an indirect effect on their patients, whether that constituted an environmental manipulation. And Howard Mann, in fact, concludes that it does. So I think we disagree with that in the following sense, that our definition actually focuses on the prospect for an individual's interest to be compromised really as a direct result of study participation. The classic instance where we think of that is where someone's physician is also a study investigator, and they have dual allegiances both to the treatment of that patient subject and also to following the study protocol. So there's a conflict, and that classically is thought to be the sort of conflict that patient subjects need to be protected from. I think this sort of indirect effect in knowledge translation studies particularly actually is different, because in those cases the physician is not an investigator but is in fact herself a research subject. And their treatment of the patients is not driven by the study protocol per se at all. That the fiduciary relationship between the doctor and her patient, I think, remains unthreatened in the sense that the physician remains free to act and advise in accord with the best medical interests of the patient. Of course, the study is all about trying to influence the physician's behavior, but I think another important part of this is these studies are all trying to influence physicians' behavior in a very particular kind of way, that they're trying to get these physicians to practice their medicine in accord with medical evidence, right? And I think those two things, to me, suggest that, in fact, the interests of patients in that sort of scenario are not imperiled in the same sort of way that we typically think makes someone a research subject. But it's a contentious point. I absolutely grant that.
Yes, I've got a question about the same thing, about this definition of a human research subject. So, okay, so next year I'm going to be experimenting with different ways of teaching statistics. Are my students human research subjects? Because according to your definition, it looked to me as if they are.
Oh, well, I haven't defined research, right? So they're only research subjects if their interests are imperiled in the context of a research study, right? And I didn't define what research was. And research I define as something like a systematic investigation designed to produce generalizable knowledge. So in fact, I don't think things like altering your teaching methods could plausibly be considered research.
But if a colleague and I decided, right, you try it that way, I'll try it this way,
right?
Have we then got to ask the students for their consent?
Well, I mean, so there is such a thing as educational research, right? And in that context, so I'm not sure if that would do it, but one can imagine, well, let's say we're going to start randomizing teachers now to teach things in different ways, and we're planning on writing this up, and we're planning on changing the way that education is delivered. Sure, I mean, there are research studies in educational settings, and many of those studies involve human research subjects. Absolutely.
And our IRB would want to know about that.
Sure. Yeah.
But I think that it's different. What Rosemary's saying is this is just an internal investigation that may influence your teaching, but you're not planning on.
Right. So it'd be like a.
No, there's actually two things. I mean, it's true. I like to investigate and experiment, but you do see people write up little trials. We decided to use Blackboard or let people use their mobile phones in such and such a way.
Yeah.
I do not believe anybody asked those students their consent.
Well, maybe they should. I mean, Look, I mean, I think education may be one area where, where the definition of research and who constitutes a human research subject is sort of underappreciated, right? So I mean, I think what I'd want to do is look at a particular case and apply our definition of research and our definition of research subject. And I think basically human subjects research falls under the purview of IRBs and research ethics committees. And I think educational research that meets those definitions needs to go to research ethics committees. It's separable from the question of whether you need consent and so on. There certainly is a gray area even in the context of health research. There's no question. I mean, I think research that purely relies on social science methods, right, even in the context of health, there's a bit of disagreement about what needs to go to the ethics committee and what doesn't. There are also, I think, difficult questions around innovative practices, right? And individuals keeping records on their own practice, right? In just the sort of way that you're talking about in an educational setting. But I think actually this definition will at least help draw that line more clearly. You may disagree with where that line is drawn, but at least I think having a clearer definition and a set of criteria will help us draw it more clearly. And then we can argue about whether it's in the right place.
In the interest of not going too far over time, I think there was a question from the back.
Oh, I was just going to make a comment that, I mean, at least in our institution, it is the that kind of research that gets into human sort of subject research violations more so than with the clinical research.
And then Simon.
I enjoyed your talk very much, and I was just thinking about your one argument for having a waiver for individual informed consent was, I think, some expression like it was necessary. Might be practical necessity if you had very large clusters. How do you regard sort of scientific necessity? So if you argue, for example, in the case of Ian White's crossover trial, you could have said that letting people go through the process of individual informed consent introduces recruitment bias which might jeopardize the scientific validity of the trial. Does that then create a necessity whereby you could say that would justify a waiver for informed consent?
Oh man, we're going to go over time now, so run while you can. Run.
I was going to ask you the same question.
Yeah, it's a fantastic question, and let me just give an inadequate answer. That was the part of the paper that we went back and forth on the most. I mean, I think where we ended up, just to give you a very brief snapshot, is to say that we thought that in a restrictive set of cases that methodological reasons could motivate a waiver in a certain set of cases. But we really wanted there to be sort of clear evidence that of this necessity, right? So clear evidence that in fact not obtaining the waiver would bias the trial so much as to make the results practically uninterpretable. And the requirement of minimal risk would still apply here. That's a threshold that runs across. I think it's really hard. And I'm still not sure that's right. So
that sounds like a very slippery slope.
Yeah, no, I know.
Okay, well, just want to say thank you very much to all our speakers this afternoon. That's been a great afternoon, I think. So let's just thank everybody again and then go off.